Oncology Summit. My name is John Walden, Senior Analyst here, and I'm pleased to have the team from BioCryst Pharmaceuticals joining us to tell us a little bit more about their program, BCX9930. To start, just want to pass it over to BioCryst Chief Communication Officer, John Bluth.
Thanks very much, John. Thanks for having us here today. Hi, everyone. Wanted to introduce Dr. Bill Sheridan, our Chief Medical Officer, and Dr. Helen Thackeray, our Chief R&D Officer. And note that all three of us will be making forward-looking statements today, and those statements have risks, so please do refer to the risk factors in our SEC filings.
Thank you, John, and thank you, Bill and Helen, for joining us. I think most people dialed in today are familiar with your candidate BCX9930, but I think maybe a good place to jump off is if you could tell us why factor D is a great target when we're talking about complement-mediated diseases, and we can go from there.
Sure, John, this is Helen. So factor D is, we think it is a terrific target, actually, for PNH and for complement-mediated diseases. Factor D inhibition has the potential for proximal alternative pathway inhibition for control of disease symptoms in PNH and control of the similarly complement-mediated systems in other disease. It adds in PNH control of extravascular hemolysis beyond what you see with the C5 inhibitors and beyond what distal alternative pathway inhibition can do. And why this is important, C5 inhibitors were a big advance in treatment for PNH. C5 inhibition is best described as giving a terminal block at the membrane attack complex, regardless of the pathway to get there. And in PNH, this addresses the lysis of red blood cells caused by that membrane attack complex. It still leaves complement covering the red blood cells. This is instead cleared away by the liver and spleen. Patients are still anemic, still needing transfusions, still fatigued. So it's a big improvement in disease, but it does not solve the problems in front of patients with PNH. So there's a remaining unmet need to address this. C3 inhibitors have the potential to block the classical lectin and alternative pathways. It's not necessary to do all of this in PNH. You just need the alternative pathway inhibition. And factor D inhibitors and factor B inhibitors, but factor D are specific to blocking the alternative pathway at the proximal point. So it's ideally suited for treating diseases of dysregulation of the alternative pathway like PNH. Factor D specifically is a target that we chose by direct choice. It is the first step in the complement alternative pathway. Starting at the beginning, it's a serine protease, which is difficult to target from a chemistry perspective. But we have excellent discovery chemists, and they have been able to achieve a potent, specific, and orally bioavailable drug. That's a high bar, and they've done it. Others have tried. At this point, we believe that BCX9930 is the most advanced, most potent, and orally bioavailable factor D inhibitor in development. There's one final point I would add for factor D inhibition, and that's that there is a structural advantage to going after factor D as your target. It minimizes the potential for off-target activity that could occur with other serine proteases. This may become a differentiator for a factor D inhibitor, as we have yet to understand that as the data bears out. But there are hundreds of serine proteases, and both factor D stands out amongst these in that prior to binding, it circulates in an inactive conformation, which is unique. It's unlike other serine proteases, which means that if you design an inhibitor to target that circulating form, it is going to drive specificity of the drug. It's not going to be like any other serine protease binding sites. So this is a unique opportunity to design a drug that is specifically designed for factor D inhibition, specific as the serine protease inhibition for factor D, and one that could deliver benefit for patients by reducing extravascular hemolysis as well as intravascular hemolysis in PNH.
That's a super helpful overview. And so mechanistically, there's a lot of reasons why to like factor D as a target and 9930 as a candidate. And thankfully, this past year, we're moving away from the realm of theoretical and seeing actual clinical data bearing some of this out. And I know you guys have ran a proof of concept study in C5 experienced and C5 naive patients. I was hoping you could tell us a little bit some of the key takeaways and maybe to start in the C5 experienced patients.
Sure. So we, as you said, we ran a proof of concept study, and in our C5 inhibitor experienced patients, we had 6. They were all anemic despite getting optimized doses of either eculizumab or ravulizumab. and we're very pleased with the results, adding BCX9930 as the first step, and then later on in the trial, in several subjects, withdrawing the C5 inhibitor with maintenance of the benefit of relief of anemia and reduction in fatigue and a reduction or elimination in transfusions. So recently, we also took the opportunity to look at the endpoints for our randomized controlled active comparator study, REDEEM-1, and apply those endpoints to that data set. And the results make us very confident that our randomized controlled trial will work out with a change from baseline in hemoglobin averaged over weeks 12 to 24 as the primary endpoint, reduction in transfusions, and improvement in the FACIT fatigue score as the other key endpoints. So we're very excited about that.
You bring up a good point. The phase 3 program, REDEEM-1, in treatment-experienced patients. Can you tell us what the primary endpoint is? And you alluded to this. What data did you see in the proof of concept that gives you confidence in REDEEM-1?
John Bluth, would you like to bring up the slide and maybe we can show the data? Great, thank you. So one of the patients in the 6 would not be eligible for our pivotal trial. That's patient K in the bottom left. So excluding that patient, we had a 2.7 gram per deciliter increase from baseline, measured in the same way that we would measure it in the randomized controlled trial. There's more than a minimum clinically important difference in increase in fatigue score. That's the right direction. So that means people are feeling better. 80% reduction in transfusions. And as you can see in the box at the bottom right, the pivotal trial is powered at 90% to detect a difference of at least 2 grams. So this makes us feel very confident that we'll get there.
It looks fantastic early data. And as we previously mentioned, you also have a bucket of patients who were naive to C5 inhibitors. What did that data look like early on? And then how does that give you confidence in your second pivotal study, REDEEM-2, which just kicked off last week?
It did. And that's an exciting step for us. So we had 9 patients who were naive to complement treatment for PNH. And these results are nothing short of spectacular, with massive increases in hemoglobin from baseline, no transfusions, 65% reduction from baseline in LDH, and more than twice the minimum clinically important difference improvement in FACIT fatigue score. So here it's a smaller study, so we don't need as big of a sample size, and we're targeting at least a 2.15 gram per deciliter increase from baseline, and seeing 3.7, clearly we're going to get there. This is, I think, an exciting step forward in PNH treatment potentially.
And can you remind us, is REDEEM-1 still expected to start before the end of the year? What else do you have to do to get that trial up and enrolling?
Yes, it is. Screening has started, so we expect patients to enroll before the end of the year.
And do you have a sense of which one you might expect to enroll quicker? Is it harder to find naive patients, or can you enroll patients after a washout period? Just how should we think about kind of speed of enrollment and when we might get data? I know it's a long way to look out in the future and a lot of things to think about, but any kind of broad thoughts there?
I think at the outer limit, we'd like to have the results from these studies in the next 2 years, but it's very hard to pin down at this stage, as we're just starting, when the patients would complete their randomized phase and enable a primary analysis. 2 things favor the placebo-controlled study. It's smaller, and the endpoint is a 12-week efficacy endpoint instead of a 24-week endpoint. So it's possible that might finish first, but honestly, at the moment, it's too early to tell.
Fair enough. And one of the main questions we get, and Helen touched on a couple of these points earlier, is how is 9930 different than the factor D inhibitors, the old, I guess, Achillion, then AstraZeneca now molecules, but and then also Novartis' factor B inhibitor. Would love kind of your lay of the land on how 9930 is different, worse, better than those other programs.
Yeah, so In terms of the Achillean molecule, danicopan, that molecule is 3 times a day dosing and paired with C5 inhibitors in order to achieve efficacy as a combination approach. So that one we don't see as competitive with primary oral therapy that would be monotherapy with twice daily dosing. The other factor D inhibitor, vermicapan, is in phase 2 and dose ranging. And so they still have some way to go to get to pivotal trials. And it's early yet to really know what there is to understand about that molecule and how to assess it in terms of comparison to 9930. Factor B inhibition is also a reasonable target for proximal alternative pathway inhibition, and the factor B inhibitor data has provided some early addition to our understanding of proximal alternative pathway inhibition in PNH. We're looking at this closely. The observations in that program have been very helpful to us, giving confidence that a factor D inhibitor is also a reasonable approach, and we would expect to see potentially similar outcomes. And in fact, the data that we have in our early work with the factor D inhibition and the proof of concept trial that Bill was just describing shows a clear improvement in hemoglobin, a clear improvement in the need for transfusions and freedom from transfusions in patients not on prior therapy, and that improvement in fatigue scores. So it's very competitive, we think, with the data that has been seen so far from the factor B inhibitor.
That's helpful, and I agree. The early data so far look very similar, which I think you'd expect mechanistically. And just last week, Novartis just put out some really interesting thoughts on the expansion and opportunity for their factor B inhibitor, which I think belies the opportunity for you guys with your factor D inhibitor. And to that point, you are starting also another basket study for renal diseases. Can you tell us a little bit about what you're looking at there, what diseases, and when that could start?
So maybe if I can give a brief comment and then ask Bill to give specifics on the basket trial. We're very pleased to be at this stage with 9930. We understand the dose for inhibition of factor D. We have the information that's allowed us to get to the pivotal program in PNH. We're now at a point where we can expand with that into other indications, and that's exactly what you're seeing with the renal study, 3 indications in 1. We won't stop there. There are other indications beyond that where proximal alternative pathway inhibition will be quite relevant for improving outcomes in the disease, and so there will be more to come. But let me just turn it over to Bill and ask Bill to comment on that study.
Sure. It's an open label, 42-patient program in 3 diseases: C3 glomerulopathy, IgA nephropathy, and primary membranous nephropathy, up to 14 subjects each. High science, recent biopsy to qualify with evidence of active complement-mediated disease in the kidneys, and follow-up biopsy at 6 months. We're measuring all of the usual things, including proteinuria, glomerular function, and the like, plus comprehensive complement profiling and disease biomarker profiling where that's applicable. So we're very excited about this and look forward to having patients come on soon.
Yeah, I'm looking forward to seeing the expansion as well. And I guess maybe as we're bumping up on our short time today, would love kind of your thoughts as a wrap up. Everyone's seen the success you've had in hereditary angioedema, having the first oral, and in PNH you have the opportunity to do that as well, but also to have even a better profile clinically than the injectables that are out there. Can you tell us what you need to show in your pivotal studies to prove that not only is it a more convenient drug, but a better drug?
So I think in our pivotal studies, in fact, we'll just be looking to show something very similar to what we had in proof of concept. That data was so strong with the hemoglobin increases that we saw. Bill was showing briefly. We saw over 3 grams per deciliter improvement in hemoglobin. We saw freedom from transfusion in the patients who had been treatment naive in PNH, and near freedom in those in prior treatment. If we see a repeat of that, which we fully expect we can do with the powering of those studies, we'll be quite pleased with that. The burden of illness is one thing, both burden of disease we are clearly seeing an improvement in. The burden of therapy is also substantial in any of these diseases. And so we expect to see not only the improvement in the burden of disease, but also improvement in the burden of therapy.
Fantastic. Well, I know we had a brief time today, but all the progress you guys made this past year in 9930 has been excited to follow, and I'm looking forward to onward and upward from here for Redeem 1 and Redeem 2, and then the renal indications as well. So you guys have a lot of work to get back to, and I'll let you to it, but appreciate the time today. John, Helen, Bill, thank you so much.
You're welcome.
Thank you very much.
Thanks, John.